Hey guys, welcome to Health Assessment Online. Let's dive into the abdominal and gastrointestinal assessment. So you can think of the GI system as one long tube from mouth to anus, where each section of the tube has slightly different function. All of the sections of this long tube have very similar layers. If you were to look at a cross section of the tube, you would see a serosal layer, a muscular layer, and a mucosal inner layer. It's the innermost layer where the function of the specific section of the GI tube takes place. So all the way down this tube you'll find a rich vascular system so that the water and nutrient absorption can easily be dispersed to the body. Ingestion, digestion of food and nutrients happens in the first half of this GI tube, and elimination takes place in the second half. So this mouth to anus tube is so incredibly long, over 60 feet, that it has to be all coiled up tightly in the area of the body that we refer to as the abdomen. Also in the abdominal space are the gastrointestinal organs. These are referred to as accessory organs because they're attached to and spill contents into the different segments of the GI tract to help with its function in one way or another. These organs include the liver, pancreas, gallbladder. The liver, pancreas, and gallbladder each help in some way for food ingestion, digestion, absorption, or elimination. But like other organ systems, you can't forget the other systems that can be found in the abdomen that may not be directly linked to GI function. This would include elements of the musculoskeletal system, vascular system, and genitourinary organs. Please review box 20.1 for further refresher on the anatomy and physiology of the GI system. One other function I think worth mentioning is the role of the GI tract as an immune defense. Stomach acid and other qualities of the GI system help protect us from everyday opportunistic infections from the food and water we eat and from bacteria and viruses on our hands and in the upper respiratory tract. A perfectly healthy and functioning older adult can expect changes in GI function as they age. In essence, everything seems to decrease and slow down. There's reduced saliva production, reduced stomach acid production, as well as slowing of gastric motility and peristalsis. The cultural considerations I feel are most important to stay aware of involve African American, Hispanic, and Pacific Islander populations. There is enormous health disparity when it comes to higher rates of hepatitis B and C, diabetes, and liver and bowel cancer in these populations. Obesity also plays a big role in the development of diabetes, especially in these specific populations, as well as just kind of in our own geographic backyard. When it comes to the abdomen, urgent assessment is required for dehydration, GI complaints that are also associated with fever, and acute abdominal pain. So those are your big top three. Emergency surgery is indicated for conditions like appendicitis, whether it's ruptured or unruptured, ruptured diverticula, or really any perforation of the bowel because the effects of the bacteria-filled bowel contents spilling into the peritoneal cavity can cause sepsis and other big problems. Other organs can rupture and cause heavy bleeding into the peritoneal cavity, and this includes a ruptured aortic aneurysm, fallopian tube from an ectopic pregnancy, or even a ruptured ovarian cyst. Of course, a penetrating trauma would require acute assessment as well. Another complication that might present as acute abdominal pain is even testicular torsion. Not all the organs mentioned here in the complications are considered GI organs, but each of these has great potential to present as acute abdominal pain. I'm hopeful at this point that you're getting a good feel for the difference between subjective and objective data. Being able to make the difference is going to guide you to better data collection, moving towards doing a more organized physical exam, and then, of course, better documentation. If you have plans to go on to advanced practice nursing, You must be able to do this. You must be able to differentiate between subjective and objective data. It's something we look closely at in major assignments in this course. If you're struggling with this concept at this point still, then please reach out to either me or Miss Browning. Subjective data collection for the abdominal assessment begins with a good health history. Keep in mind, many of the concerns and complaints involved in the system are affected by intake. So food intake, water intake, special diets, alcohol, medications, vitamins, and the plethora of over-the-counter medicines that are targeted for the GI system. Our patients have access to a literal wonderland of over-the-counter meds to choose from when they're self-treating for GI complaints at home. So be sure to ask about these meds. You may even want to look at packaging because the ingredients are important and can vary. For example, hemorrhoidal cream, Preparation H. Preparation H has probably 3 or 4 different ingredients that can be in the cream. Sometimes it's just a menthol, sometimes it actually has hydrocortisone, and so looking at the packaging can be helpful. Please spend some more time reading the history and risk factors table that begins on page 547. The nurse holds the responsibility of helping the patient to reduce risk and promote health of their GI tract. The 3 main topics we need to target are, with risk reduction and health promotion, are colorectal cancer, foodborne illnesses, and hepatitis. Colorectal cancer is the 3rd most commonly diagnosed cancer and the 2nd leading cause of death in the U.S. African American men are more than twice as likely to develop colorectal cancer. Risk factors for the development of colorectal cancer include advancing age, personal or family history, history of inflammatory bowel disease, not irritable bowel syndrome, but inflammatory bowel disease like Crohn's or ulcerative colitis, and then also having diabetes. Now, let me take a minute to differentiate between non-modifiable and modifiable risk factors. Non-modifiable are exactly that. There's nothing you or the patient can do about that risk factor. It is what it is. These are still very important for you to know, though, so you can identify those who are at greatest risk for development of the disease and make the appropriate recommendations for them. Modifiable risk factors are risk factors that you and the patient can work together toward improving or changing so that you can decrease the risk of developing the disease. If a patient has numerous non-modifiable risk factors for a disease, then you really need to work even harder on the modifiable ones so that they don't add up and up and up to put the patient at even higher risk for development of something like colorectal cancer. I like the modifiable ones because then I don't feel as helpless in making recommendations to patients. Patients will ask, well, what can I do about this? And when you think about modifiable risk factors, you can give recommendations. So non-modifiable risk factors for the development of colorectal cancer are, I said, advancing age, personal family history, inflammatory bowel disease, and diabetes. Modifiable risk factors are things like sedentary lifestyle, a diet high in red and processed meats and alcohol, obesity, and smoking. The American Cancer Society recommends screening for colorectal cancer. Your book lists the many options for doing so on page 550. Keep in mind that the gold standard screening test for colorectal cancer is the colonoscopy. Despite all the other options like Hemocolt testing and things like that, the colonoscopy is what is recommended. American Cancer Society recently released recommendation to begin screening at age 45, but your book is a little behind and still says age 50. Foodborne illness is related to pathogenic organisms, and these can be a significant cause of foodborne illness, and the risk for this arises from things like improper food storage, handling and preparation, international travel or imported foods, and contaminated water. As the nurse, provision of education in these areas can really help your patient reach their objectives for GI health. As far as hepatitis goes, please review this on page 551. Practice question number 1. What is one topic pertinent to abdominal health promotion? Think health promotion and the abdominal system, okay, because that's what is in the question. Early pregnancy care is good health promotion, but it's the gynecologic system. B would work. Foodborne illness would work, yes. C, respiratory disease, well, no, C is the respiratory system. D would also work, so which is esophageal cancer. So B and D look good. D, esophageal cancer, this is where you have to pick the best answer. And your book prioritizes foodborne illness, colorectal cancer, and hepatitis for GI health. So the best answer is going to be B, foodborne illness. Esophageal cancer might work, but it's not as significant in its incidence and mortality for our country as colorectal cancer is. And so the answer is B, foodborne illness. The 3 areas of focus involving the GI system, as listed in your book, prioritized as colorectal cancer, foodborne illness, and hepatitis. You can see some of the more common abdominal symptoms listed here. Symptoms are still in the subjective data category, so these are descriptions that the patient will provide if you ask the right specific and targeted questions. Take some time to read through these questions that are related to the specific GI questions beginning on page 551. The nurse is going to need a stethoscope and a pillow to place under the patient's knees for comfort and to relax the abdominal muscles. The advanced practice nurse or nurse practitioner would then also need a measuring tape, skin marker for measuring the size of the liver. The APRN would also need a tongue blade to elicit the abdominal reflex. The advanced practice nurse is also responsible for the different maneuvers used to evaluate ascites and inflammation of the gallbladder and the appendix. So for your purposes, preparation for physical exam includes a stethoscope and a pillow. Of course, of clinical significance is the difference in order of assessment in the abdomen. Inspection is followed by auscultation for bowel sounds before percussion and palpation. If you auscultate last, then you may have altered the sounds, the GI sounds, by palpating and percussing, and that is the reason why there's a little bit different sequence in the GI system. Always, always, always start with inspection in your physical exam, in your physical exam documentation, and in your subjective documentation, asking if the patient has inspected and noticed any changes. This picture shows the lateral view, but some sources recommend viewing the abdomen from the foot of the bed up towards the head of the bed because it tends to give you a better view of symmetry and pulsations of the abdomen. Inspection also has the potential to reveal distension, striae, scars, or hernia. Auscultation of the bowel sound should begin at the ileocecal valve just below the umbilicus, little to the right, just below the umbilicus, and move clockwise. Listen to each quadrant for a full minute. If there are no sounds, bowel sounds, then you would listen up to 5 minutes. Now, in your demo video, it's okay to state out loud that you, quote, would listen to each quadrant for 1 full minute, rather than actually doing so, because it will eat up way too much of your time. So do not actually listen for 1 full minute. State it out loud so that we know that you know that that's what you would do. In the average healthy adult, you should hear about 1 bowel sound every 5 to 15 seconds. I posted the slides above as a reminder just that the nurse needs to also note vascular sounds. This is done in the areas noted above with the bell of the stethoscope because the bell is going to better reveal bruits, venous hums, and friction rubs. So in this first picture here, you'll see you shouldn't hear any vascular sounds in the abdomen. but listening with the bell over these areas might reveal changes in vascular sounds to the renal arteries, iliac arteries, or aorta. Percussing for kidney tenderness at the costovertebral angle and percussing the liver are depicted above or in the picture. Percussion of the liver is an advanced practice nurse technique. You'll also need to percuss each quadrant of the abdomen for fluid, air, or masses in the area. Percussion may also tell you about tenderness, but we use more palpation for that. The abdomen should be mostly tympanic. You'll note dullness in the liver in the right upper quadrant and hollow tympanic notes in the left lower quadrant over the gastric bubble. But sounds really are going to vary depending on the patient's last meal, where their stool bolus is, and any gas that they have in the GI tract. The first picture, entitled Kidney, is an example of proper hand placement when checking for CVA tenderness. The outside hand is doing a quick hard thump on the back of the other hand as it's pressed firmly against the flank of the patient. So that hand on the flank is right there at the costovertebral angle. A positive sign with CVA tenderness is quite obvious because the patient will literally jump up from the table in pain if there is an underlying hydronephrosis or inflammation of the kidney. A positive is commonly found in pyelonephrosis, obstructive kidney stones, and the finding of CVA tenderness can be unilateral or bilateral. So just a quick thump on the back and you say, "Does that hurt?" And they go, "Oh, yeah." That's not a positive. When you see a true positive, you'll never forget it. The patient might swing back and try to smack you. Percussion of the liver span is an advanced practice nurse technique. See your Bates videos for more information on all of these techniques, as they can be difficult to show in simple slides, and that's why we use Bates videos. Single or double hand technique of light, medium, and deep palpation, pressing upward. So you'll see that in the first picture, palpation. Pressing upward on the flank or the back of the patient while you're palpating above the liver will help kind of sandwich or compress the liver to make it easier for you to feel. Using the hooking technique is pictured here on the top left picture, well, top right if you're looking at it. That's the hook technique to be trying to feel for a liver border. Do not palpate the abdomen of a patient who has had an organ transplant or a child with a suspected Wilms tumor, because these organs and tumor tend to be very anterior and very poorly protected. Considerations for the older adult are listed here. A few I've already mentioned. Processes just tend to slow down and decrease in function, and organs tend to shrink. A complete blood count may be useful in assessing for anemia and infection. Comprehensive panel gives you insight into the patient's blood glucose level, which is a function of the pancreas, electrolytes, kidney function, liver function tests. Esophagogastroduodenoscopy, EGD, easier to say, allows for camera visualization of the upper GI tract, and this procedure allows also for biopsy of the lining of the bowel if indicated at the same time. So it's a way to investigate problems but also diagnose if you can get a biopsy. Barium enema is a procedure where contrast is instilled in the lower GI tract and then radiologic imaging is done. This type of imaging can also be done with air installation, and these tests aid in the detection of inflammatory bowel disease and also tumor. ERCP, endoscopic retrograde cholangiopancreatography. If you just break up that big word, it tells you basically what's going on here. It's a lot like an EGD, where a camera is used to go in and visualize the GI tract, but the ERCP specifically looking at the little tiny ducts that connect the pancreas to the small intestine and the liver and gallbladder to the small intestine. Remember, these are accessory organs that do their job and then secrete their secretions into the small intestine to help you absorb food. So the pancreas secretes enzymes, the liver secretes bile to help you emulsify the fats that you eat. But there can be blockages in those little tiny areas, or you can get stones. So the ERCP is helpful in not just diagnosing that, but also, again, opening up some of those ducts and also removing stones, so it can be a treatment as well. All of the important nutritional absorption happens in the small intestine, so when problems occur here, this is where you see more changes in the patient's weight and more signs of malnourishment and dehydration. CT is radiographic imaging of the abdomen that can be done without contrast or with oral and or IV contrast. The test will still show soft tissue tumors and abnormalities when, so a CT scan will show soft tissue tumors and abnormalities when contrast is used. When contrast is not used, a CT is more useful for looking at dense material like something with a kidney stone. So don't need contrast when you're looking for something hard like a kidney stone, but when you're talking soft tissue, contrast, either IV and GI or one or the other, is usually indicated because it's going to illuminate the lining of the bowel and tumors and vascular changes better. A more complete list of nursing diagnosis and the associated intervention can be seen on page 570. Practice question number 2. Mrs. Jones presents at the emergency department complaining of severe pain in her abdomen. She has a history of a liver transplant. What should the nurse know not to do? The answer is palpate the abdomen, because transplanted organs often sit very anteriorly and they can be unprotected. And so pressure being applied to them can cause damage more easily than in an organ that is not transplanted. Here's a hint that might help you with some of your assignments. In each chapter of your text that we cover, there's a section entitled Comprehensive Physical Assessment. And in each of those sections, you'll see a column called, quote, Technique and Normal Findings. Under that column, there are little icons that look like little tiny folders, and those icons tell you what the normal finding should be for each component of the physical exam. The wording that's used there by those little folders is a great jumping off point for what details you need to include in your objective write-up, because most of you will do your physical exam on a mostly healthy individual. So use that resource. Also, you also have the section of each chapter called Documenting Case Study Findings to help guide you. All right, that's it for this lecture. Thank you.